Good morning, everybody. I would like to thank the organizing committee for giving me the opportunity to present my talk about molecular classification of breast cancer, a retrospective cohort study. My name is Professor Fatma Al-Thoubaity. I am a surgical consultant in the Faculty of Medicine, King Abdulaziz University, Jeddah, Saudi Arabia. And this is my hospital. And this is the Annals of Medicine and Surgery in which the paper was published in January 2020. As we all know that breast cancer is a heterogeneous disorder, representative of numerous subcategories of several cellular composition, molecular alteration, as well as clinical behavior. A number of factors such as histological grade, type, and size of tumor, lymph node metastasis, estrogen receptor, progesterone receptor, and human epidermal growth factor receptor, HER2, new influence the prognosis and the response to the treatment of a breast cancer. In the United States, an estimate of about 250,000 new cases of breast cancer were recorded in year 2014, which in turn accounted for about 14% of all new cancer cases. In United Kingdom, about 15% of all new cases of the cancer. Incidence of breast cancer is much lower in the Kingdom of Saudi Arabia. In Saudi women, breast cancer is the most common malignancy, and it accounts for about 27.4% of all of the newly diagnosed female cancer. And according to the cancer registry in Saudi Arabia in year 2010. It is worthy to note that the incidence of breast cancer is lower in KSA. Age standardized rate per 100,000 is 29.6 as compared to the worldwide average age standardized rate per 100,000 is 43.1. In United States, the mean age of diagnosis of breast cancer is 61 and above. But in Saudi Arabia, the mean age of diagnosis is 49. So we have a cancer in a younger age group, less than 50, and it will be aggressive and locally advanced cancer. It is estimated that more than 450,000 deaths occur annually due to breast cancer worldwide. Molecular subtypes of breast cancer based on histological grade and lymph node metastasis are strong prognostic and predictive factors. Classifying breast cancer into relevant molecular subtypes is an important aspect of therapeutic decision making. Classical immunohistochemistry markers such as ER, PR, and HER2 play a crucial role in a molecular subtyping. Newer methods like gene expression profiling using complementary DNA microarrays have been developed, which are the therapeutically important for molecular classification. Immune histochemical analysis of a tumor on the basis of status of ER and PR and HER2 is used in clinical practice. Immune histochemistry-based molecular subtyping of tumor is now considered as the mainstay to predict susceptibility of tumor to hormonal therapy and subsequent trastuzumab therapy. According to the St. Gallen consensus in 2011, they classify breast cancer into luminal A, ER-PR positive, HER2 negative, and low Ki67. Luminal B, ER-PR positive, HER2 negative or positive with high Ka67. HER2 overexpression in which ER-PR negative, HER2 positive, triple negative breast cancer in which ER-PR and HER2 all are negative. Basal-like subtype of breast cancer referred to as triple negative breast cancer was found to be positive for basal marker CK5/6 expression. The objective of our study is to determine the distribution of various breast cancer molecular subtypes in Saudi Arabia and associated clinical pathological feature. This is a retrospective study over 7 years from 2012 to December 2018. We obtained the following parameter: age at the time of diagnosis, tumor size, histopathological type, the grade of the tumor, the presence or absence of carcinoma in situ, lymph node status, immune histochemical profile of the hormonal receptor ER-PR and HER2 in invasive malignant cells. The tumor size measurement was retrieved from the ultrasound report of breast prior to the biopsy or using report from the other radiological modality. And according to the size, we classify either less than or equal to 2 centimeter, or if it is more than 2 and less than or equal to 5, or we classify it if it is more than 5 centimeter. Tumor grade was classified into grade 1, 2, 3. 3 is high grade according to the percentage of tubular differentiation, presence of nuclear atypia, polymorphism, and the number of mitosis. The ERBR and HR2 tests were scored according to the guidelines of the College of American Pathologists. Positive ER or PR is considered when more than or equal 1% of invasive malignant cells that exhibit nuclear staining or immunoreactivity. Additionally, for ER and PR, another semi-quantitative scoring system called quick scoring system was employed to ascertain the proportion of stained cells and assess the intensity of nuclear staining. The HR2 test was scored from 0 to 3, in which score 0 or 1 are negative, 2 plus is equivocal, 3 plus is positive, 3 plus score is given when an intense full circumferential cytoplasmic membrane staining is observed in more than 10% of invasive malignant cells. Specimens showing equivocal HR2 staining were sent for further examination with the help of fluorescent in situ hybridization FISH, and their result will be documented. In our paper, we classify breast cancer into 4 molecular subtypes: luminal A, ER and BR positive, HR2 negative; luminal B, ER, BR, and HR2 all positive; triple positive, EHAR2 positive, in which ER, BR negative and HR2 mu positive; triple negative, ER, BR, and HR2 mu negative. You can see in this figure that the commonest type is luminal A, 58.5%, followed by triple negative 16%, then luminal B 14%, and HR2 11.5%. We can see in this pathological specimen ER-BR positive staining and HR2 here negative. Here is HR2 positive staining and PR negative staining. ER-PR negative staining. We use statistical analysis for social science software version 21. Our results showed that the mean age of diagnosis is 49, and the most common cancer histopathologically is ductal carcinoma in situ, about 85%, followed by lobular carcinoma, invasive ductal carcinoma, 85%, followed by lobular, 11.4%. And the rest are other type of cancer like medullary, tubular, mucinous, metaplastic, adenoid, cystic, and encysted papillary carcinoma. The average size of the tumor at time of diagnosis is 3.2, so it's large size. So most of the patients, they have a tumor size between 2 to 5, about 48.9%. And in about 42.6%, they have tumor size less than 2 centimeters. The patient whose age was less than 50 years had a higher probability of displaying greater tumor size. So with the younger age group, they have higher tumor size than the one who are at 60 or older. More than half the cases, about 66.6%, they have positive axillary lymph node metastasis. So in this table, you could see the age. We have 59% of our patients, they are younger than the age of 50. And the commonest type, molecular type subtypes is luminal A, 58.5%. And for the tumor size between 2 to 5 is 48.9%. So most of them, they have tumor size larger than 2 centimeters. And in 42.6%, they have tumor size less than or equal to 2 centimeters. And positive lymph node in 66.6%. Positive ER immune staining was found in 70.8% of cases and the PR in 63.8%. HER2 immune staining was found positive in 18.7% of cases and equivocal in 22.8%. FISH testing was performed for the equivocal cases and it was established that 34.2% of the equivocal cases were HER2 positive. Higher frequency, 66 to 70.5% of HER2 positive and triple negative tumors was observed as compared to the luminal tumor in patients whose age was less than 50 years. HER2 positive showed tumor mass size greater than 2 centimeters in 82.5% of the cases, Triple negative tumor have a tumor mass size greater than 2 centimeters in 75% of patients, where the majority of the tumor size ranged between 2 and 5, 65 and 59%, while the rest showed tumor size of more than 5 centimeters, and about 15.4%. These subtypes showed aggressive microscopic feature, and approximately 2/3 of these subtypes demonstrated poorly differentiated carcinoma. HER2 positive tumor were observed to be displaced least frequent as an in situ component, about 41.2%. Lobular carcinoma were found almost exclusively in luminal A and triple negative tumor subtype 77%. 69.5% had modified radical mastectomy and 30.5% had breast conserving therapy. So high rate of our patients, they have mastectomy because the tumor is advanced and locally aggressive. Survival rate was found to be 90%. This table, it shows us the histopathological characteristic of those molecular subtypes. As I told you, the most common histopathology is in 85% is ductal, invasive ductal carcinoma. And the tumor grade, we have grade 1 in luminal A, 62.2%, grade 3 commonly in triple negative and HER2, 68.4%. And we have carcinoma in situ commonly in case of luminal A and less common in case of HER2 positive patient. In the present study, 42.6% of the patient had a tumor size less than 2 centimeters. This implies that there is aggressive presentation and delayed diagnosis in the Saudi population, which may be due to the lack of awareness in community about breast cancer, as well as absence of a comprehensive screening program. The findings in our study relating to the distribution of molecular subtypes was found to be in concurrence with the result obtained from a study originating from various Asian and Western countries. We found that in different countries like Oman, Poland, China, the most common type is luminal A, 34.7% in Oman, Poland 69%, China 46.5%, in Tunis 50.7%. And we have one study also in Saudi Arabia was done in 2010-2014. Also, the most common also type is 58.5%. 375 patients is luminal A. In contrast to our study, about half the cases, 52.8% in the study by Tamimi et al. Were found to be triple negative, while luminal tumor represent 28.5%. So this is the only study which is against our study. In the current study, we identified a strong association between different molecular subtypes and lymph node status, with 82.3% positive lymph node involvement in HER2 positive cases. One of the limitations are due to the unavailability of Ki67, a cellular marker that differentiates between non-HER2 expressing luminal B from luminal A tumor. Similarly, limitations are in the detection of basal-like tumor as a subset of triple negative tumor due to the absence of cytokeratin 5/6. There is a discrepancy rate of 39% in the molecular classification of tumor by immunohistochemistry and gene expression. So in conclusion, the most common tumor subtypes are the luminal A, followed by triple negative breast cancer. Luminal A and triple negative tumor were found to be closely linked with increased frequency of lobular carcinoma. The HER2 positive and triple negative tumor were associated with increased frequency of large tumor size, poorly differentiated carcinoma, as well as more aggressive manifestation of cancer. HER2 positive tumor were less frequently observed in carcinoma in situ. We also observed a strong correlation between lymph node status and molecular subtypes. This phenomenon needs to be examined urgently, addressed, and early screening mammography should be established in KSA. We also recommend in-depth investigation into the risk factor associated with different molecular subtypes of breast carcinoma in KSA. It's also important to investigate the effect of different breast cancer subtypes on the prognosis and survival of the patient. Thank you very much for your listening. And if you have any question, you are more than welcome. Thank you very much.